Uh, Thank you so much for that very kind introduction, and thank you to the GASOC team for the opportunity to present here today. As was mentioned, my name is Mike. I'm a PhD student at Cambridge in the International Health Systems Group. I'm a surgical registrar from London, and I'm the lead investigator for the GOL trauma study, which we'll talk about shortly. As my background, I've previously worked as a medical officer in Ghana, as well as being a surgical registrar in the UK. This talk that I'm going to give today, that I've titled is High Quality Research Possible Within the Realms of Global Trauma Care. And I thought I'd summarize initially, particularly about trauma, but a lot of this is relevant to many of the topics that we know within global surgery and anesthesia as well. And before going into talk more about some of the challenges that we faced running the GOLD trauma study, and some of the advice that I would give for anyone who's considering running a multi-center study. So a bit of a background, I'm sure many people appreciate this, but trauma itself is a massive burden globally. Approximately 10% of all deaths that occur worldwide are associated with trauma. It affects young people, so therefore there's not just issues with mortality, but it's also issues with mobility and disability with economic impacts as well. And unfortunately, it's often the resource poor areas that whilst they'd have the highest rates of trauma, they also have the worst outcomes as well. But when we try to improve trauma care, it becomes quite complex. We know that lots of different parts are involved in the care of a trauma patient, from the time of injury and the pre-hospital care through to everything that goes on in hospital and all the specialties that are involved, all the way through to rehabilitation and getting them home. And that's where my group in system engineering at Cambridge comes into thinking about this. So when we try to think about how best to try and understand the complex problem of trauma care globally, well, trying to run a multi-center study within that context of systems thinking seems to be the best way forward. But within trauma itself, and trying to get quantitative data, there are challenges already that this begins to pose. For those of you who've worked across multiple healthcare settings, you know that the challenges and the journeys that these patients take from trauma care are very different. We're trying to fit quantitative data, often with these multi-center studies, into very bounded data points. And that becomes very challenging, that whole square peg in a round hole. The storytelling aspect is often much more challenging, because it requires a lot more resources involved. And whilst it does give that richer picture, it can be a lot more challenging. So how we tried to unpick this complex issue further was, well, we picked the signal procedure, something a way we can try and standardize across settings. So we did use the trauma laparotomy as an example, and the reason we chose that was because we know that in global surgery, the laparotomy itself has been used as a bellwether procedure. And within trauma care itself, it is a core procedure, both for perforated viscus and for hemorrhage as well. For trauma laparotomies, we found it was a useful metric to use. This is not just the mortality rates that can be compared, but there's other morbidity and health economic measures that can be used. And thinking back to that systems point, well, there's lots of specialties that are involved in the care. It's not just about the surgeon doing the procedure, but it's all those bits of the puzzle which come together that can really be used to build that greater picture across. So we found that doing the trauma laparotomy procedure was this perfect way to try and unpick this quite complex picture. This is on a background of a few other collaborative works, and I'm sure many people are aware of this. The great works done by the Birmingham group from the Global Surge Collaborative have looked at elective general surgery procedures before. There's been some work on trauma laparotomies done by the TILA team in London, mainly UK-centric, and one of the NIHR neurosurgery groups in Cambridge has previously done looking at neurotrauma with the GENOS study. So we went into the goal trauma study with a rationale of why we wanted to do the study from a systems perspective, the data points we wanted to unpick, and the experiences from some of this previous work. So that's when we proposed the goal trauma study. So the global outcomes after laparotomy for trauma. I'm pleased to say we've actually completed this study now. It finished earlier this year. The study has been accepted in the Lancet Global Health and is due for publication this year. But I will just summarize a bit of the study now. The aim of the study was to evaluate sort of the patient factors, the injury factors, how they present to hospital, what procedures they undergo, what resources are being used in the hospital, and the outcomes there. So we really tried to pick these data points that map that journey. And one of the many slides that I'm very proud of is this one. We found such a strength of the study was using multiple organizations to support this work. I see that obviously GASOC was instrumental in supporting this, but we were able to implement multiple groups from across the world in supporting and disseminating this, both European Trauma Society, Latin American Emergency Medicine Societies, and Sub-Saharan African General Medical Societies. So we're very grateful for the support that the study received. As a brief overview, like many of these observational cohort studies, this was multi-center. Any patient who presented to hospital with a blunt or penetrating injury and underwent trauma laparotomy within 5 days was included in the study, and this included any age range at all, so both including pediatrics and adult patients. Really important to this, and I'll come back to later, before we started the study, we piloted the study not only in Cambridge but in Kampala in Uganda to reflect a difference in resource settings. Whilst we got ethical approval from Cambridge as well, we received local approval from every contributing site. And this again is just to demonstrate one of the real strengths of collaborative research and observational studies is you can really begin to unpick that patient journey through some of these data points that we've included. I won't go into all the data points that we collected for, but understanding the time of injury, time to presentation, decision to operate, the operation started through to the time of discharge really allowed us to better understand how the variation occurs across settings. We translated our protocol into numerous languages as well, which I'll come back to later. This is an example of our French protocol. And one of the other slides that I'm very proud of, and this is the number of recruiting centres that we had. So we managed to engage across all continents, apart from Antarctica, collaborating centres, and in the end, we ended up recruiting 1,769 patients. We had 187 hospitals enrolled, and it was 51 countries that we were able to recruit from. And what I was very humbled by was that we were able to engage and people would work with us from very challenging areas that are both in active conflict or in humanitarian crises. So, for example, from Ukraine, Sudan, Yemen, occupied Palestine territories, Somalia, the DRC, and Haiti, we have collaborators who are contributing data to our data set, and I'm very grateful for all of this work. So that's really a summary of where we've been so far, and now just moving on to the challenges that we've faced in conducting global collaborative research. And many of these, whilst you can plan as much as possible, I really found some of these were really caught us a little bit by surprise. Many people face communication issues, varying internet or 2 or 3G signals, so trying to find ways in which your collaborators are able to collect data, whether this is on paper data collection forms or just ensuring flexibility in your data collection windows. We found that our central administrative team in Cambridge were very stringent in some of the processes that had to go ahead, whereas in other countries where there might not be the same level of hospital infrastructure or administrative support, trying to balance these things up became quite challenging, and a degree of flexibility and pragmatism was certainly required. I mentioned before about the heterogeneous patient journeys. Patient really varied across from setting to setting, and really trying to fit the data set to match so all these patient journeys could be fitted into the data collection. And then things just as like securing basic resources for data collection. I was made aware by one collaborator who understandably was not able to use the data collection form because they didn't have regular access to paper to print on. And so just trying thinking of ways and adapting and working with the collaborators was certainly a way to come around that. So what advice would I give to anyone for conducting such research? We're very lucky that we had a very experienced advisory group who are involved. So we made sure we had people from multiple specialities across multiple settings who were involved in the design and the running of this study. And I think one thing I really want to emphasize is when you develop these protocols, make sure you get as much experience and knowledge in when you might have their own idea in your head of what you want to do and what your study wants to be, but you really need to make sure that you've got as much input as you can and listen to these people's experience because it will pay dividends later on. When you have your data points, make sure every data point is as clear and as focused as it can be. If you don't think that data point is going to be used in your data analysis at the end, don't include it. Collaborators are often giving their time essentially for free in know that they're paying forward in collaborative authorship for such work. So you don't want to be giving them unnecessary work. So make sure every data point you ensure to use. Make sure you pilot the study beforehand. We both found really important points when we piloted the data in both Kampala and in Cambridge. Simple things you might not think of in your own setting, such as the regularity by which temperatures are measured in patients when they present to emergency departments. And when we realized that in many settings that wouldn't be feasible, then that was dropped from our data set. And so that was ensuring we can ensure a high level of accuracy from our study. Make sure you give collaborators multiple lines of communication. I gave my phone number out to multiple people just so they could WhatsApp me, because in many settings that's so much easier for people. If they want to email you the data collection forms, make sure you can do that way. Just try and do as much as you can to allow for ease for collaborators who are working with you. I found translating the documents into as many languages as possible was really useful, and making your website to set this stuff up just really easy for people to use. So they access, they know how to go through it. So just before I finish, I just really want to just focus on some quotes from collaborators they had. And I mentioned earlier how humbled I felt from running this study. And I genuinely just want to touch on this before the end. These are two quotes I've anonymized from some collaborators who contacted me regarding their involvement in the study, just to really contextualize some of the challenges. So for the top one, due to the ongoing war in Sudan, it had effect on our hospital, which was located, meant we were not able to add some further cases to the study due to issues with communication from loss of internet connectivity. We hope that our small contribution was valuable. And then the other patient was from from a collaborator in Ghana, where they said the patient was officially discharged on one day, but then they actually stayed in hospital for another 4 days due to financial constraints, really emphasizing that sort of heterogeneity and variability and often these patient journeys, which sometimes these studies don't unpick. So to summarize, uh, quantitative data it is feasible to do in these big global surgical studies. We've demonstrated that in our trauma data set, and these are feasible in many of the other collaborative works that's been done. The real take-home points that I would say is make sure you're really careful in your data selection points. Make sure you get multiple groups to help support you. Make sure you have all the relevant experts in when you're designing these study. And I have to say it's been an incredibly enjoyable, humbling, and eye-opening experience through from running this study. So thank you for the opportunity to speak. I'm happy to answer any questions now, or that's my email address should anyone wish to contact me. Thank you.
Oh, thank you so much, Max. It was great to hear about, yeah, the whole journey of kind of setting it up to seeing it through. Um, I'll wait to see if any questions come through in the chat, but I've got a couple for you if that's okay.
Sure.
Um, so I suppose one of the questions I have listening to you, you can see how the data gets collected from such a wide number of places and made into one study. How do you find disseminating that works back, taking kind of lessons that you're getting from pool data and applying them to different individual contexts?
Yeah, that's a really good question. We found that making sure that the data is available to the collaborators that analyze it how they wish as well. Whilst, yes, collaborative research is really good, big data sets are really powerful, but at the same time, collaborators, they're inputting their own data to this. So you want to make sure that they have access to their own data as well. We've had numerous collaborators asking for how do they access their data once they've inputted it into the system. So we're sending them back the data they've so they can analyze, they can drive local change as well, and really better understand their data set. So I guess in answer to your question, making sure it's not just that one direction of data flow that occurs, but making sure that, yes, it's great to have big data sets, but we need to make sure that local collaborators are using their data that they submit as well for their benefit locally.
Yeah, absolutely. Yeah, I think we've got okay, we got a question in the chat. Um, it says, how did you get buy-in from other centres abroad to participate in the study, and what local support did you have? Do you have local principal investigators or similar?
Yeah. That I mean, that's pretty much that's the golden question, really, because it is really challenging to engage collaborators. Certainly in trauma care, especially like it's fast paced. People don't have the time. It's a challenging environment to work in. And then you're saying, well, here is more work for you that we can't financially reimburse you for because an observational study. So it becomes really challenging. We were able to have country leads who are disseminating it. We were able to engage well through social media for certain areas. We had the multiple organizations who were involved. So there's no real one answer, I guess, I can give. It's just constantly using any way that you can, whether it's word of mouth, email threads, social media, to try and disseminate and get momentum behind the project. People need to believe in your project as well. They need to see it and go, yeah, this looks like something that I'm going to sacrifice my time for free because it looks like this is going to genuinely benefit me and the wider academic group. So I mentioned about having a clean looking website. I know it sounds quite a simple and obvious thing, but making a snazzy looking website with a few like easy pictures that understand it, a bit of any infographics, protocols which are easy to understand, just so people can have confidence in your work that they're not going to give their work for free. So doing all those sorts of things, I think, is probably one thing that I would advise. And the other thing, we're trying to be as flexible as you can in the communication platforms. When we first started, and this is probably naivety from me, I just presumed email would be sufficient. I slowly realized that, again, through my ignorance, that email is not the way to be dealing with this. It is through whatever means going, whether it was on social media or WhatsApp. I mean, I certainly found WhatsApp of just messaging people so much easier to ensure recruitment.
Great. Well, thank you so much for that. I
Thank you.
think we'll move on to Afra if that's okay. If no one has any more questions for Mike, but we can also, if you do, you can put them in the chat and we can come back and ask you after Afra's talk if you're
Great. Thank
interested.
you.
So next we have Afra Jiwa. So I'll pass you over to her if you can share her screen and tell us what she's been working on.
Hi, everyone. Nice to meet you all. Thanks so much for joining today and for listening to this talk. I really enjoyed Mike's talk. I thought it was great. So I'm nervous now to share mine, which is a little bit more general, but hopefully it'll be a slightly different approach to sort of collaborative studies and my experience of working with them. So just to introduce myself again, I'm one of the run-through trainees up in Scotland, and I've taken a break, or I've interrupted my training to do an out-of-program for research, which means that I'm currently doing my PhD at the University of Edinburgh. I work very closely with the Global Health Research Unit and Global Surgery, but I've also taken 2 of those years and worked with the PGSSC, which is the Program for Global Surgery and Social Change over at Harvard Medical School, of which some of my time was spent in Boston and Rwanda. And so I'm just back to the University of Edinburgh, which is where I am now. I guess I'm going to be talking you through a little bit about what I've come to understand about HIC LMIC partnerships in general, and then specifically within the context of collaborative studies. So I guess the first thing, just to take a step back from all of this, is to understand what HIC and LMIC partnerships are overall. And these sort of exist in lots of different contexts, but specifically sort of between low middle income countries and then high income countries. They can focus, or they often focus on health, but they can be within the realms of like education, research, capacity building. And often one of the big aims is to share resources and expertise to address health and development challenges, and often within the context of collaborative studies or research. So these can be specific, as an institution to institution, which is what we call a bilateral partnership, or multilateral, which is sounds a little bit like what we've already heard about from Mike, which is networks or consortia, or many institutions linked to a single unit in some ways. And the aims are that it's meant to be very mutual. So it's meant to be about improving health outcomes, not just for one country, but globally, by having that sort of sharing system, about strengthening those partnerships, advancing education for individuals, and a big resource exchange. And then, of course, funding and training and infrastructure also comes into that as well. So HIC and LMIC partnerships can run at different scales. So they can be sort of country or state or citywide. A nice example I have is that Glasgow is twinned with several institutions worldwide. They're actually twinned with Palestine, which I really enjoy as sort of a fun fact. And sort of that often can form a foundation for, again, when people are looking to find resources to give or information sharing, often that's like a place to start. They can be organizational. So I did my master's at the London School of Hygiene and Tropical Medicine, and I spent part of my training time over at the MRC unit in the Gambia, because they have a new partnership that's forming there. And the University of Edinburgh and the NIHR Global Surgery Unit partners closely with its unit hubs sort of around the world. And that's an example of an organizational partnership. And then they can be individual, which is perhaps less talked about and less common, and has lots of sort of other ethical things attached to it, which we can maybe discuss later. But that's when individuals form partnerships between HIC and LMIC environments. So collaborative studies in particular are often when these bilateral or multilateral organizational partnerships exist. And then within that, people look to establish research opportunities between those two organizations. And there's lots of different benefits to doing that, both for the LMIC partners and also for the HIC partners. So for the LMICs, you get access to funding often, there's infrastructure, there's equipment, there's massive capacity building if this is done correctly. So this means there's opportunities for individuals and organizations to develop in their training, their mentorship. You can build new skills, a lot of upskilling going on and learning from perhaps more skilled individuals in other settings. You get lots of visibility, so opportunities to publish and to establish a research background, and again, to learn how research works in areas where more funding is available. And then you get an opportunity to influence global policy and agendas, which is a funny way to phrase that, but essentially what it means is that once you're giving voice to people in LMIC environments, they then will influence global policy and global health outcomes, which is really important and often really overlooked. And there's a funny statistic which says that, I can't remember off the top of my head, it basically says that most global health policies which apply to the majority of populations in LMIC environments are obviously written and developed by HIC partners. And so you're just giving, again, more agency to people about whom often these policies and laws are written, which is really nice. For HIC partners, you get access to unique research settings and data. So at the moment, if you are an individual doing a study in a high-income environment, your data set is likely to be that same HIC environment. So for example, if I was a PhD at the University of Edinburgh, I might conduct lots of my studies at the Royal Infirmary of Edinburgh, which means that you're going to be limited in the kinds of patients that you're going to see. It's definitely not representative of our global population as it stands right now. And again, you'll get lots more variety in terms of conditions, patients, procedures, that you would see if you were working on a global scale. And that's sort of particularly relevant nowadays as we start to develop data and train models and algorithms and bots and things on our big data. It's really important that our data is representative of our global populations. And so one of the ways to do that is to make sure you're conducting research in settings that are representative of the global population. There's lots of opportunities for innovation in resource limited contexts. So I don't want to sort of imply that this is a guinea pig system, but essentially a really interesting thing to do in general is to try something out in a resource limited place, which might not have the same access to medicine or healthcare or technology that you do have in a high income environment. And that's not always a bad thing. Sometimes it's well known that technologies can help you leapfrog developments in healthcare. So a common example that people like to use is when we think about sort of communications, there was a time where no one in the world was really able to communicate with people in their environment very easily. And then sort of HIC environments progressed slowly, and then people sent letters, and then after they sent letters, or they had messages, and they had letters, after letters, there was emails, and then emails, there was phones. And what's happened now is in loads of environments in which sort of person or point-to-point messaging still exists, now mobile phones have just kind of jumped 4 of those steps and overtaken that as the means of communicating with people locally. And so technology has really allowed these opportunities to provide like leaps and bounds and advances in low-income environments. And I think HIC partners are often really excited to test their technologies out in those settings. And then there is sort of lots of mutual benefits. So in environments, especially HIC environments where funding is really quite settled, you then get to sort of get these, I like to call them like cherry on top opportunities, even though they should really always be the core of what people are doing in these HIC LMIC partnerships. But that just is the idea that you can really build these collaborations that are so fruitful in terms of like long-term relationships, both personal and professional. They outlast single projects, they're career development opportunities for both parties. There's a huge opportunity for cross-cultural learning and innovation and exchange. I, for example, have benefited hugely from the relationships I have with my partners and the fact that I've been able to spend so much time in country. And then, of course, the research becomes really relevant as well, because you're developing solutions that are context appropriate, again, for our sort of changing world and for our global populations, and for our multinational organizations. So they can be really wonderful opportunities to do good research. However, there are lots of risks that are associated also with doing collaborative studies that really people need to be mindful of them, and it's important to think about them as you set up and develop your study. So the most obvious one is that there's still always a power imbalance. There's a long legacy, especially with the UK, of colonial history, and people need to be really mindful of how that translates into sort of modern day colonialism. Often the HIC partner is controlling the funding, which means that you're also setting the agenda, the priorities, the timelines, the outcomes. And it's very often the case that a partner might choose a health priority that just isn't as applicable in a low income environment, but that's just because what the trends are following. For example, a really good example I like is sort of the Gates Foundation, who of course does loads of good, but they often will choose funding sources that are relevant to sort of what is trendy at the time. And at the moment, AI and big data is very, very trendy. And that means lots of funding is going into those projects that are focusing on those things. And infectious diseases is largely on the out, but that's still a problem that affects many people in many LMIC environments. The funding just doesn't follow that or doesn't go in that way anymore. But that's not to call out the Gates Foundation. They do obviously do lots of good, but that's just the example that often comes to mind. Tokenism, so LMIC partners are included on grants to satisfy grant requirements. So again, you become more eligible for XYZ grants, especially global health grants, if you have an LMIC partner, but they haven't necessarily always played a huge role in developing the protocol or in writing the grant. But it just allows companies and organizations to effectively say that they work in LMIC environments or in global health, even though it's really just a sort of, again, tokenistic. So extractive research, so data and samples being taken from LMICs without fair benefits sharing. What that means is that you can instruct or advise your collaborators to collect data for you, and then take it from the country without really considering who that data belongs to, and what ownership they have over it. And again, if you were then taking that data, writing a paper, publishing it, and not giving fair attribution to your partners in those countries, then that still maintains sort of this power imbalance in these research environments. And some countries are finding ways to overcome this. So in Rwanda, for example, there are really strict laws about what data you can take in and out of a country. And many other sort of sub-Saharan Africas are following that and saying that data needs to stay in country, but it still exists, sadly. Short-termism, which you might have heard as a trending term, but it's very common. So when projects end, when the funding ends, so you have a big project, it goes really well, the funding cuts out, and then that's sort of the end of the relationship and the end of the project and the end of the jobs for people who have been working on this project for a long time, and they don't tend to be sustainable solutions, which is something that tends to be quite important nowadays. Different priorities. Again, I think we've talked a bit about this. So a project meets a donor need, but not a local need. Brain drain is an interesting one. It's one that's sort of contested and debated quite a lot about whether this is a positive thing or a bad thing. And there are lots of different sort of schools of thought on where that stands. But one school of thought sort of says that we shouldn't be HICs should not be encouraging brain drain. And what can happen is you will provide a lot of training to an individual. So if you can imagine, there's a very skilled surgeon working somewhere, they start to join a collaborative research project, they upskill substantially in the realm of academia, and this then through connections promotes them to then leave and restart or continue their career in an HIC environment. And what that then does is essentially leaves a gap where there would have been a skilled surgeon who's now then transferred over. And that is often or can be exacerbated by the role that sort of health research plays, because often what you do see is then people who have trained in medicine or in surgery, then moving into academia, and remembering that often the availability of places at medical school or the number of people who are able to train in medicine and surgery in some places is very, very low. And so it's perhaps in the UK, I certainly know that we don't have an excess, but we have a huge number of doctors for whom it's very normal not to continue in healthcare training. But that isn't necessarily always the case in other places. And it really is a loss of skilled staff. And that needs to sometimes be taken into account when considering these relationships. And then I will skip over a couple and just talk about inequitable authorship, which again is sort of an emerging concern at the moment. And the idea that, again, you can work through and build a huge study, have it be extremely successful, work really well with these people, build a really long-term relationship. But ultimately, when it comes down to it, you have either a single LMIC author named for people who have worked really hard on a project, or actually no LMIC authors will contribute to the writing of it. And they essentially act as just data collectors for what should otherwise be an equitable distribution of work. And all that does is then promote individuals in HIC environments to progress with their academic careers, to increase their authorship, when that doesn't then extend into their partners in LMIC environments. So I'm going to talk a bit about my experiences of collaborative research. So I have just spent 2 years as a research fellow at Harvard Medical School. So Harvard Medical School is partnered really closely with an institution or a charitable institution called Partners in Health, which was founded by Paul Farmer, who was a medical anthropologist who worked really hard throughout his life, and he died a few years ago. And they have sites in Haiti, Peru, Russia, Rwanda, Lesotho, Malawi, Kazakhstan, Mexico, and the DR. I specifically spent a lot of time in Rwanda, because that's just where my particular projects were being executed. And I spent 6 months there in my first year and 4 months there this year. And I was working primarily on executing a cohort study. This is sort of my office block out in the village on sort of the western border of Rwanda. And I would be there every day working on this project here, which is to do with post-operative infection of cesarean section wounds. And what we were trying to do was establish an algorithm that would detect surgical site infection in a post-cesarean patient in the immediate sort of post-operative period, with the idea that you could administer this application via a mobile phone, which was being handled by a community health worker. So somebody who's otherwise not medically skilled and only had sort of limited training in health management. With the overall aim being that if you can train an algorithm and a phone and a community health worker to do this kind of risk assessment, you are really minimizing the number of women who then need to return back to a healthcare center in the post-operative period, once they've otherwise will have restarted work and childcare and may have returned to the village. So this is largely what I spent my time doing. It was a project that's sort of been 10 years in the making. It was being guided and led quite heavily by the Harvard Medical School team, but it was being executed entirely on the ground in Rwanda by the Rwandan team. And then I was sort of there as the liaison between those two parties. And I spent my time doing that. And that was one of my experiences. And the other one is that I'm a PhD student at the University of Edinburgh. And we do things a little bit differently here. We work with the GSU, which is also probably about 10 years in the making now, maybe a little bit longer. And in this role, I look at wearables in the post-operative period, which I'll talk more about in a moment. This differed in lots of ways, and I'm happy to answer any more questions about this. But primarily, this was, instead of this being a bilateral exchange, so Rwanda, Boston, this is multilateral, which meant that I was an Edinburgh trainee working in Edinburgh with Central Edinburgh team, but with all these hub sites in 7 international sites. In 7 sites, sorry, worldwide. And so you're not just collaborating then with one person, you're collaborating with 7 international sites and an infinitely larger number of people. And I didn't necessarily do an extended period of time on this one project, though, of course, while I was in Rwanda, I was also working on this project because that was also running in Rwanda. But we do end up doing sort of more frequent and short-term visits. So we were in Mexico about this time last year on a trip. We went to Nairobi in between that, and we were in India just a couple of weeks ago, doing some work on that. And just to be a little bit more specific about what this study entails, we have wearable sensors. So we have an example of them here. They're known as sort of the ANI-1. You have a chest sensor, which you can see on the left, and then a limb sensor, which goes on your finger. That's on the right. And what we do is we put those sensors on patients before they go into surgery. They'll wear the sensors both through the operating period and then into the 10-day post-operative period. And in that time, what they will do is they will continuously monitor all of your baseline OBS. So your heart rate, your rest rate, your temperature, your blood pressure, and your oxygen saturations, with the idea being that they should be able to replace what is currently a full-scale and largely wired up ICU-grade continuous system. And if we can manage this, and if we can get these sensors onto enough patients, what you should be able to do as a very long-term goal is do quite high-level and high-detailed post-operative monitoring for patients who otherwise would basically have no monitoring. And you can do this with a limited number of staff, and you can do this at a lower cost than what's currently being executed. With the idea being is that if you are able to monitor patients to that degree and with that degree of sensitivity, you should be able to detect post-operative complication much easier than it is being detected at the moment. And by doing so, we can improve our failure to rescue rates globally, because that is a huge problem that is killing many, many patients who undergo surgery, both in the UK and worldwide. So just a few considerations about working on these projects. So the first step with both of them was ethics. These have to be done locally. I did them both at Harvard and Edinburgh, and then you do them abroad. Different etiquettes at different sites. That means trying to support your partners in submitting their ethics, different amendments, different local guidances, making sure that your project is sort of aligned with the local governance in each site. Then there are culture differences. So I see it a lot with our Edinburgh team and the Edinburgh study that we run here. And it just means that there's lots of variation in what's expected of you professionally. Some of our colleagues will work through the day and through the night, and you can reach them anytime, any day. And via phone or via email, or they're very in touch, whereas that's not the case in other places. There's different understandings of work-life balance, of when you can be contacted, when you can't be contacted, socio-political norms, so things that are okay to talk about, things that are not okay to talk about, whether it's okay to have sort of a friendly relationship with your partners, or whether it should be strictly professional, whether it's gendered in any way, whether there's hierarchical differences. So all things you're trying to be mindful of, but you're trying to run the same study at different places. So it sounds like what you should be doing in theory is using a protocol and just administering the same thing everywhere. That hardly ever plays out that way. You're essentially, in lots of ways, running 7 micro studies in 7 different places. Lots of resource differences in different countries. So again, I think Mike was talking about this. In one place, you'll say, please print out the protocol, and they'll do that easy peasy. They'll want to do it on an iPad. In another place they'll say we actually don't have enough ink to run the printers, the electricity's gone out the whole day, we haven't been able to participate well. Digital literacy varies between again your partners, so that just means that with resource often there is a difference in how capable people feel with administering technologies. So for some people, you're explaining, okay, this is how you run code to analyze this data, and then in other places you're talking about how to charge an iPad or how to switch that on. And again, keeping all of those partners sort of, or trying to get everyone at the same level and administering the same amount of training can be really tricky when you're dealing with such variation in how people work with technologies. So equal buy-in from other partners, this is something, again, the Edinburgh team feels really strongly about. So it's not just about equipping people to be data collectors and for being extractive. Like data and the data quality is so important to our studies, and data collection is a huge part of any study. But what you also want to do is try and upskill people. You want them to be analyzers, paper writers, data cleaners. You want them to do everything in that study as much as you can. And so what we try and encourage is for people to do as much as they can of their study locally, and we help with training. And we try and support them in that rather than just instructing them on what they should and shouldn't do for us. So on an everyday basis, what this means is that lots of meetings. So whether I'm in Rwanda or whether I'm in the UK, I'm often glued into my screen. So trying to speak with all our partners internationally. When I was in Rwanda, that was a lot of more in-person meetings, but again, really the same thing. And you're often doing time zone, what I call time zone math, like calculations, like trying to work out how you can get people across 6 different time zones into one meeting, which the answer is it's impossible. Don't ever try it. It's not going to happen. And so it just means you have to do the same meeting several times over to meet with lots of different people. Studies, even when they're very straightforward, seemingly very straightforward, will require a lot of explaining, translating, reiterating, reclarifying, re-instructing people on what you're hoping to achieve with it. And doing things at scale in different countries with language barriers, with different customs can be tenfold harder. So you spend a huge amount of your time trying to find ways to articulate what you're hoping can be a straightforward concept, or something that seems really easy for you can actually be really difficult to people who don't have the same context as you, either as a medic or as an academic, or just, again, like being based in the same country. So I spend huge amounts of time developing resources to help with that. Understanding the strengths of your partners and supporting and building them up, and like supporting them in their training. That's really, really important. So again, both with the Harvard team and with the Edinburgh team, what we're trying to do is guide and support, but also recognize the strengths of your partners, recognize their insights, recognize what they're adding to your study, recognizing that they're people who really want to thrive in academia, and doing what you can to support them in upskilling, which links really nicely into training time. So often on a regular basis, we're running some kind of training scheme in Edinburgh, which means that people can be developing their qualitative skills, their quantitative skills. They can help with data cleaning, data analysis, answering general questions. Like, we often have access to our partners in that way, which means that we hope that they are up training. The Harvard Medical School does this a bit differently. They will come over 2 or 3 times a year to run a year-long training course, which is called the Intermediate Operational Research Training. And essentially people will come for, again, week-long periods 4 times a year to go through several sets of quite high intensity research training opportunities, with the idea being that you are trying to build a team of really proficient academics and researchers who can then ultimately do their own research after you've left and try to make a more sustainable project. And then, of course, there's lots of fun. So we get to visit them and they get to visit us, which is really nice. Like, it's a wonderful perk of the job, and is a really, really nice thing to see the people who you've worked with in their sort of local setting. And it's also really lovely to host them. So we have a really big meeting coming up in September, where we'll be hosting all of our collaborators from all 7 sites. And I'm sure it will be chaotic, but will also be really good fun. And a really nice chance to sort of see a lot of our data in action. And I think it's when you have those moments that you really, truly understand the value of what it is that you are trying to build in a collaborative study.